So HYPERACT was, the name came from Hypercapnia randomized controlled trial. And we need to really start with, why do we care about COPD exacerbations? Well, again, this is the area where people from a very purist standpoint talk about ventilation. COPD exacerbations, and to some degree asthma exacerbations, are all about CO2 removal. It's not just about dumping oxygen in, right? And so everyone agrees that our device, as well as a bunch of other ones, are great oxygen dumpers. But what about getting the gas exchange? What about getting the CO2 off? And so we look at COPD for two reasons. Number one, it's a big market. 500,000 to 1.5 million visits to the ED a year, right? Those translate not just to 140,000 deaths, which is tragic enough, but how many of you have got a loved one, especially over the age of 40 or 50, who when they go to the ER for anything, that week is a good week, right? It wrecks everything. Your schedules, your childcare, they feel bad. Even if they get out of the hospital, right? Their cough lingers for another month. So these 500,000 to 1.5 million ED visits represent life impact. They're lost days of work, they're lost days of doing things we enjoy, they're lost days of being in our families, they're lost days of our lives, even when we're not dead. So that's the impact of COPD, and that's one of the reasons we cared about it. Scientifically, the reason we cared about it was exactly what I just described. We wanted to be able to look at pure CO2 removal, and in the purest way that you can in actual humans. So here's the thing. Most ER docs don't think they have a problem. It is very difficult to get someone to spend money on a device to solve something that they don't think is a problem, right? Like that. The only reason I go shopping for something is I have a need. Well, sometimes I just shop, but in general, right? You go to the store because there's a need that you have. A lot of the ER docs are unaware of the fact that they have a need, and the reason is because it's just entrenched, right? BiPAP treats COPD great, and it was so much in a doctor my age or older's lifetime. The BiPAP revolution came through, and it was so much better than how we used to manage them, where they all got tubed and mechanically ventilated, that it feels like a victory. Like I'm thinking to myself, I'm so much better doctor than my predecessors. I put them on BiPAP. So unless you point out to them that they have a problem, which is actually not that difficult, you just have to get them out of the fast brain into the slow brain and actually go, hey, do you have a problem? And then they think to themselves, man, I'm having to sedate them. In one of the studies, the Cortegiani study that we've discussed, 8% of those patients required sedation of the patients who were on bilevel pressure. So if 1 out of your 10 patients have to be sedated, well, there's not great data on a single dose for sedation, but we do know that if a person over the age of 60 is discharged from the emergency department with a sedative medication, a prescription, they have a dramatically increased mortality rate in the next 30 days. Sedating people is not insignificant, particularly when they have increased secretions, right, to aspirate on and to settle down into those lungs. They're at risk for falls. They're all on blood thinners. I mean, right, it's just like a just pile of bruised bones and body fluids. It's a disaster. So sedation is not an okay thing. Decreased venous return. When you put positive pressure intrathoracically, right, you can even try this sitting right where you are. It's more eventful if you do it while standing, right? Suck in a big breath, bear down really hard. One of you, we can probably decrease your venous return enough to make you pass out. Cool party trick, don't recommend it. But my point is, if it can make you go unconscious, how is that a good therapy for I'm not breathing, right? Like intuitively, we know there's a problem here. What are the consequences of the lack of humidification? Well, this is one of the ones that Dr. Meltzer pointed out. We can have real problems with secretions. And this is something that, it's an oldie but a goodie for our stuff. Our stuff humidifies really well from moment one. Most patients who get put on a BiPAP in the ER, I was stunned when I found this out, by the way. I found this out from talking with you guys. The RT doesn't have time to go put on the humidifier right now. So even though the manufacturer recommends that and that it should always be used with a humidifier. In real life practice, that doesn't always happen, and these patients will go 8, 10, 12 hours. Well, how long does it take to get mucosal damage? 30 minutes. 30 minutes. So it's a big deal. Obviously, barotrauma is an issue. Popping a lung is an issue. Pulmonary contusions causing bleeding, all those things are an issue. And of course, we've talked about how staff intensive it is. It's staff intensive because it's annoying to the patient, which means they're on the button constantly. Pressure injuries, obviously, are a big deal. Frankly, you don't see a ton of those in the ER. They don't happen that fast. It tends to be more of an ICU problem. But this ability to eat and get oral medications and things is a big deal. And one of the reasons is, if I'm an ER doctor, I need you to get medicines right now. I have a lot of people who can go to the Pyxis and get them and hand you tablets. I can only have a few who can do injectable medicines, or worse, if it's something that has to be mixed and sent from pharmacy to hang in your IV. So there's a huge push throughout America to move to oral medicines for as much as you possibly can. It's just infinitely faster, and we know it's effective. It's also cheaper. Do you know what my hospital charges to give you an IM injection? $150. It's not the cost of the medicine. That's not the cost of the needle. That's the cost of the nurse jabbing you. Because we have to keep a nurse there 24 hours a day with the lights on, able to do that. And because it's presumed that you are sick enough to not be able to swallow your antibiotic. So that's why. But every time you can cut out those kinds of things by letting a patient take their medicines, for example, you've paid for their circuit by letting them take their steroid instead of getting injected for it. That's all it takes. 1 decadron injection versus PO steroids. So the ability to eat and drink and talk is a big deal. When any of these goes wrong, of course, it can be catastrophic, right? The patient becomes, can at times decompensate and need all these other interventions. But the worst one they may need is to go onto a mechanical ventilator. And you guys all know even better than I do this, all of that. So the question became, is it real? We all know why. Once you point this out, it becomes obvious that we would love for there to be an effective alternative. But is it really good for patients, right? Because even if those things are all those things we just talked about with BiPAP are not great, but they're way better than not breathing or death. So, right, everything's about perspective. But what if there is something that we can do that's truly non-invasive? And that was the hypothesis, that high-velocity therapy would be non-inferior to pressure-based therapy for providing relief of moderate to severe hypercapnic dyspnea. Now, why relief of dyspnea? Yeah, great. So it's the symptom. So when the patient comes to me in the emergency department, they don't say to me, oh, my CO2 level's high and I have relative acidosis, I think, right? It's never happened. What they do is they come in and say, I can't breathe, doc, fix me, right? So, and by the way, within some degree of, it's not that I don't use numbers, but I often don't recheck blood gases after therapy. Do you know how you know when the patient's better? They start asking for the chicken sandwich, right? They're like, I don't want to be here anymore. When you have the reserve to yell at me and curse in 4 languages, you're ready to go home, discharge. It's good. So what we used as a very clinical endpoint. All right, so here it is. 7 hospitals, a variety of practice styles, 3 academics, 3 very community, 1 was military, all across the country. We already talked about we use dyspnea as the primary outcome. And so dyspnea is measured on that smiley face scale, right? You've all seen the super angry to super happy. I think that, by the way, I think the board scale was the birth of the emojis. I'd just like to point that out. So the smiley face scale, so the research coordinator would hold it up to the patient, and the patient was allowed to choose and rate where they are, and we then converted that into a numeric score. Population, these were kind of a needle in a haystack a little bit. Had to be an ED presenting symptomatic patient that with known or suspected COPD. Now, why did we do known or suspected? Well, the reason is because to get known COPD, you have to have followed up outpatient with a pulmonologist and had pulmonary function tests consistent with COPD, and by some guidelines with more than 1 reading in the absence of an acute illness. I don't know about your ED patients, but my ED patients usually don't care whether we get them boxed in exactly correctly. So following up with those appointments is all that's difficult. However, as a physician, when the person comes in and says, I started smoking when I'm 12, I'm now 70, and they look like little feet and lungs, and they say I can't breathe, I'm pretty confident I know what I'm dealing with. So what we allowed was known or suspected COPD. Suspected COPD also qualified if you'd had prior admissions for bronchospasm or sort of any variant of that. And then the biggest thing was they got a blood gas, and the pH had to be 7.0 to 7.35 with a concomitant elevated CO2. Now, you'll notice there are some other studies out there in the world that deal with some of these patients. They have an elevated CO2. They don't have a dropped pH. So what does that tell you about the patient they're studying? That's a chronic hypercarbic patient. But when you have an elevated CO2 with a low pH, concomitantly, what do you have? You have an acute decompensated COPD patient, right? So we took these patients and we randomized them 1-to-1 high velocity to bilevel pressure, and this little table at the bottom tells you their mean values at randomization. So their PSU2s, the mean was 77.8 and 76.5. The pH was 727, and they all rated themselves moderate to severely dyspneic. And so those were our baseline patients. Most people in the room who, of the clinical folks in the room, would you argue that's a relatively sick patient? Yeah, so for me, I rate degree of illness is based on whether or not I have to get out of my chair in the ED. So this is one that my residents and I, we call this a butt off the chair patient. So we have to get up, go see them. Like that one's, you can't go get your Snickers first. So the other thing, though, we wanted to know was all the other stuff we're interested in, right? So our secondary outcomes, we measured vital signs, we made sure they weren't hypoxic, all the things you would expect. We measured blood gas changes and continued to rate their dyspnea. And then we, what's one of the hallmark of our therapy? It feels better. So we measured comfort ratings. All right, so this is, again, just another way of showing you what we did. 68 patients, 1-to-1 randomization. We talked about it. We used a non-inferior design measuring dyspnea. Dyspnea is the actual symptom you're treating. But does BiPAP relieve dyspnea? Yeah. So when you have you're comparing against a therapy that works, then non-inferiority is what sort of makes sense. And then what becomes superior is, to some degree, a subjective statement, right? So is the therapy superior if it's more comfortable? Well, if you're the patient, it is. But from a purist statistical statement, that may or may not be an outcome that you care about. Do you understand the difference? So we go with non-inferiority because, in fact, it may be unpleasant, but positive pressure does work. It blows off CO2. So these were the initial therapy settings. So for high velocity, we asked them to start at a minimum of 30. And remember, these are mostly COPD. They're not terribly hypoxic. So we did an FiO2 of 50%. And for positive pressure, they got 12/6, also 50%. Importantly, I can't stress enough in this study, because it is a theme through it. The clinicians were not bound by the study in any way. So they could start them on this, and they could, in 3 seconds, turn them to whatever settings they believe they should be on. Treating the patient was paramount throughout the study for obvious reasons, for safety, but also just for ethics. So while these were starting settings, it doesn't mean the patient stayed on them for any length of time. They could have adjusted one way or the other very quickly. All right, so a consort diagram, for anybody who may not be familiar with it, is the diagram that you see in every paper that should tell you where every patient went. The most important thing about a consort diagram is that somewhere at the end of it, all the numbers should add up. So you should account for what happened to every patient. And what you'll find is that we had 400 and some odd patients that were assessed. Ultimately, 73 got randomized. because as they begin to explore a little further, remember this happening in the ED very quickly. If it turned out they had a big pneumonia, a big infiltrate on chest x-ray, these are the things, those were not the patients we wanted to study in this study. Those would have been patients we would have kept originally, for example, in the Doshi study. We wanted all comers. But here, remember, we were trying to find this pretty pure population. The important thing to note on the right is that the groups were pretty similar. We had male, female, slightly larger number of patients that were non-white. And that's actually a big deal in the research world, and that's something I'm really proud of. Throughout the United States, one of the major problems we have is that the populations who may benefit the most from some of the questions we're studying are not well represented in the research trials. As you would guess, at higher academic centers, often are associated with socioeconomic classes and are also disproportionately white. And so we're actually really proud of that. It's a big deal that we were able to get a lot of patients of different backgrounds into this study, because a lot of patients of all different backgrounds get COPD and benefit from our treatment. Patients were, averaged around 60 years old, and they were neither extremes of BMI. We had a couple pretty small ones. As you know, with COPD, when your BMI goes very low, that's a poor prognostic indicator. But we also didn't have any extraordinarily large BMIs in this particular study, which would have been challenging, right? Because then you have obesity-related hypoventilation syndrome that you have to factor in, and we didn't have that. So basically, they worked out. The bottom line is everything on the right side looks pretty similar between the two groups, and that's what you want. So here's our primary outcome. When you took these patients and you monitored them for 4 hours and you asked them at 30 minutes, 60 minutes, and 4 hours how they were feeling and how their relief of dyspnea was, what you found is they got better, the therapy worked, and interestingly, it was statistically non-inferior at every time point except the baseline. So at 5.58 and 5.31 are statistically considered within random of one another, but it's statistically non-inferior at each time point. So that was a primary outcome, and we met it. Met it and said, look, this works. High velocity therapy works here. This is a different form. I'm going to give you each of our graphs. I'm going to be giving you in 2 forms. All of our materials come in 2 forms. One has the line graphs because we think they're a little clearer, they're a little easier to see, and depending on the audience that you have, that might be the more optimal way to present the data. These are the ones that will be in the dot and whiskers, are the ones that will be in the actual manuscript, and particularly your physicians are probably more interested in seeing these. They give you a lot more information. So briefly, how do you read one of these graphs? Well, inside the box is first you'll see a solid line, and the solid line is the median. The dashed line is the mean, and the box represents the interquartile range. The whiskers out on the end tell you the full range, and some of them you'll see an occasional dot. That's a discrete outlier. So you'll see those in a minute. So by following particularly the means, which is the dotted lines, you can probably get the best indicator that would translate into this. So this is the much more simplified version, but this tells you the whole range. I actually think there's a lot of data in these that are really valuable because it tells you, for example, that some of our patients responded much faster. Like if you look, for example, in the 30-minute with the positive pressure group, what you'll find is that mean was there, but that median was up pretty high. They had a bunch of patients who didn't respond well in that first 30 minutes. Then what else did we say? Well, great, we met our primary outcome. We did it. I feel like I should just drop the mic and walk right there. We did it. But what do you really care about when you're treating a COPD patient? I mean, absolutely, on the one hand, you really care that their dyspnea is relieved, they're ready to eat, they want to go home. But how do I know that that's really safe? Well, I need to look at their blood gas parameters. If you notice the slope of the blue, on the left-hand side, the pH, the blue line improves much faster, right? Like it shoots right on up there. That's actually we've seen that before on information that says, listen, put it on for an hour. They're either going to shoot up there or they're not, right? How do you know if someone's going to fail? And the reason that's valuable is because it can allow the physician and the RT and the nurse and all the people to feel comfortable that they know they're not going to be surprised. They know how to monitor this patient, and so then they're more willing to try something new. So great, non-inferior. This is what it looks like here. Remember when I was saying that a dot can be an outlier? Actually, this is one of my little favorite moments in this data. This pH of the 60 minutes, there's one patient, this occurred in my hospital, by the way. There's one patient where the patient became alkalotic. Now, what happened to that patient? They were on positive pressure and left on positive pressure, even though they were better, because the staff didn't get back to them fast enough, because codes came in and broken bones came in and all the things that happened in ERs. And so the mask didn't come off. So we actually deranged a patient because we overtreated them. Is that possible on our gear? Why? It's an open system, right? And it's not sealed. So you notice there's not a single blue dot up there. And the reason is because patients can open their mouth. So that was kind of cool. Other physiologic measurements, heart rate, respiration rate, intubation rates, they were all the same, which nobody got intubated, so that was good. That's not shocking. We know BiPAP works. We know it can be miserable, but it works. One thing that's interesting is that there were a couple differences. More patients were admitted to ICU on our gear. Now, if you talk to the PIs, that has to do, we think, more with hospital policies and simply where people are designed to go and stuff. But we're doing actively working on a subgroup analysis, and objectively, it is possible that our patients the patients in the high velocity arm were actually a little sicker by classic scoring systems. So we're working on that subgroup analysis, but some of that is simply a function of where beds were available, hospital policies about where patients on high flow or BiPAP go, those kinds of things. But interestingly enough, 11% of patients on our gear were actually discharged home. Now, one pressure-based therapy patient did actually complete the trial and was off of pressure-based therapy at the end of 4 hours. So arguably would have been a treatment success. But what was interesting is the physician still wasn't comfortable sending them home. Whereas our patients, they did. I don't know what that means, but I know as an ER doc, if you tell me suddenly I can get 10% of my COPDers out possibly, that's going to make me at least want to have a more significant conversation. So the other thing is failure to tolerate. The patients, as you might expect, had a lower device failure rate compared to the pressure-based therapy. So just their willingness to keep it on and feel better. Overall levels of patient discomfort. So this, let me be clear about this. This is overall level of sort of distress that you're reporting. This is not angry at the mask. This is how sick I feel, how all the components of mask or nasal discomfort can be part of it, but it's overall level of misery. And it's interestingly, the patients who were treated on high velocity therapy, their comfort improved steadily. They started out really uncomfortable and steadily got better. The patients on mask-based therapy were uncomfortable, actually got more totally uncomfortable, and then sort of gradually started getting better. And it's because they were adding in the discomfort of the mask and the claustrophobia and the struggling to get this to start turning around and working, right? And interestingly, at the end of it all, they rated themselves more total discomfort at the end of it than they started with. That is really not the goal of medical therapies, right? So to me, I really enjoy this graph. Here it is. Same data, overall levels of patient discomfort. And what I like about this, though, by the way, is it shows that there's tremendous variability. right? We all know there's some patients who you put a mask on. Every now and then you get a patient who knows the mask works and they'll ask for it, and there's how one guy told me he likes it because his wife can't talk to him. So, I mean, right, there's variability in our patients, and we should recognize that. We need to be very authentic with and transparent about that with our customers and with the clinicians that are caring for people. So there's a big range, but when you're looking at it overall, the trend is clearly there and is statistically significant. The other thing that came, now this part is not part of this first draft of manuscript, but it's in the study, and so I want to go ahead and educate you guys on it. It's kind of interesting because I think it tells us a lot about the clinicians we're working with, and the relative comfort level they have with our device versus pressure-based therapy. I mean, you heard, again, these were two of the more aggressive, forward-thinking PIs, and they're still very much like, well, my comfort zone is positive pressure. So, number one, we asked the clinician, the physician, to on a scale of 100 put an X that says, how stable do you think this patient is at the end of the 4 hours? And what you'll find is it was indistinguishable. They're pretty much the same. We also asked them, did you get the outcome that you expected? And lower is better, by the way. So they actually, rated that their expected outcome was achieved a little bit more frequently with the BiPAP arm. Well, why might that be? Yeah, it's anchoring bias, right? Of course I think my outcome is expected. It's what I expected, right? Like, so that's okay. By the way, none of these are statistically significant in their differences. Patient comfort and tolerance, they did indicate they thought that probably the high velocity seemed a little bit better. And ease of use, in retrospect, we didn't ask this one very well because now I'm beginning to understand that it's ease of use for the physician is always exactly the same. They go to the computer and punch into an order. It's the ease of use for the RT. We asked the wrong person that question. There's some study limitations that you need to know about. No one could be blinded, right? Because there's no way I can make it where you don't know if you're getting BiPAP or a nasal cannula. So we can never have a true blinded study. These patients, we did our best to get the pure COPD exacerbation, but you saw the reason all those ones had to be excluded was because patients are more complicated. A patient with a pneumonia who's very dehydrated, will have a negative chest X-ray, and it's just because they haven't hydrated it out to fluff it out yet. You guys all know that. So there could have been some early pneumonias. There could have been, there's lots of patients who had concomitant CHF that could have been a contributing factor. What we do know is at the time they were randomized, they had an acute respiratory acidosis, right, from their elevated CO2. But there is patient heterogeneity that always occurs. All the patients receive standard care, so things like dispoing to the ICU, that can be much more a function of your hospital policy than, or even just that one particular doctor, right? I have one ER doctor that I work with who believes that only patients should only ever go to the ICU from the EDU. I'm convinced. They're like ankle fractures, like, oh, he might need an extra nurse to help him get in the bathroom. So it just depends. Patients were able to provide verbal consent, and that was sort of by necessity, right? So somebody who's too somnolent, and we did have a couple of GCS-14. They were somnolent enough to be confused that we were able to bring into the study. But, patients who are in acute sort of extremis you need to be careful before you extrapolate the study to them. So a patient that's still verbal is really who this study studied and who we should be talking about with our clinicians. And importantly, remember, our gear all over it, every qualifier is for spontaneously breathing patients. So if they're so somnolent they've gone apneic, we're not the right gear, probably. And then last, we did use some subjective measures, right? We used the smiley face scales, because we had to. We were trying to measure things that are, in fact, subjective. So, of course, our measures had to be subjective. But those are all limitations that we should be aware of. This study was conducted right in the middle of COVID and on the front end of COVID. So that may have also contributed to some of the ICU dispositions and things with hospitals having the belief that all respiratory distress goes into ICU at the very beginning of COVID. And that was part of how they were cohorting patients and things like that. So what do we find? High velocity therapy works. It's non-inferior to positive pressure at reducing dyspnea in 4 hours for acutely hypercapnic patients. By the way, I don't mean a little bit acutely hypercapnic. I mean really sick patients. More than half of the patients in both arms qualified as moderate to severe exacerbations. They had PSO2s over 70. They were really sick. They were a couple hours from somnolence and death. So it worked. It worked great. It brought the pH down, or pH up, excuse me, and the CO2 down at a similar rate, arguably slightly faster. And the patients liked it better. They felt better. The clinicians liked it. It's the things that we've been saying, but it's really solid evidence. It says we independently went to 7 different places around the country on both coasts, rounded up all these patients, and they all said the same thing. The manuscript concludes with high velocity therapy is a reasonable alternative for patients with acute exacerbation of COPD who present to the ED. That is about as strong a statement as academics are likely to ever make in a manuscript. But I think what it means is it gives permission to try, right? It says, listen, this is reasonable. We have all gotten together, these really smart academic people, we've said this is a reasonable thing to do.